Hi, I'm Dr. Tony Mork. I'd like to talk a little bit about just where your hands are supposed to be to hold these instruments. It's always a little challenging in the beginning, and I thought I would just give you at least my interpretation. I think everybody's got different size hands and maybe a different preference how to hold these, but I'm going to show you what I do. It seems to have worked well over the years. So the first thing that happens is, and I am right-handed, so I'm going to be holding the tube with my non-dominant hand. So I'm going to be holding the tube because when I work with the instruments, I'm going to be using my dominant hand. So for those of you who are left-handed, something to consider. In any event, the sequence for placing the tubes is always going to be the same. You're always going to be placing an obturator, and you're going to most likely find something bony to put the obturator on. The second thing is going to be the placement of the tubular retractor. And just remember that the tubular retractor has a bevel at the bottom. The bevel always points away. It's actually matched up with the hash mark here, a black hash mark on here. And I always face it away from whatever I'm doing. Then there's a fluid restrictor which goes on the top, and then it just bevel away from you. So the obturator is in the proper place. The tubular retractor is going to end up going over this. And now just remember, it's the same concept whether I'm holding the obturator or the tubular retractor. I'm always putting a little pressure on the obturator to dock it on whatever bone I'm on. I don't care if it's a cervical facet or a lumbar facet. I'm always docking it on some bone so that the tip of this is not wandering somewhere where it's not supposed to be. At that point, you can slide your tubular retractor over this. Again, I'm going to put some pressure on up here, and I'm going to follow it down so that the tip of the tubular retractor is going to be docked on something as well. At that point, I'm going to pull my obturator out, but I'm still going to be holding the tubular retractor just like this. Now, I can switch hands if I want to adjust anything. But really what's going to happen in the beginning, I'm going to just be holding it like this, and I've got my bottom 3 fingers here. The next thing that's going to happen is I'm going to be putting the scope in, and the scope just goes right down like this. At this point, I'm going to do it from the side here. At this point, I can use my finger as a stop here so that the scope just doesn't go flying in. I want to start a little bit above the operative area, and then I want to have it get down to about, maybe here. At that point, I'm going to turn on the water supply, and so I can start to clear the operative site, fill it with water. The light source is there, the camera's there. This is the working channel, meaning that I've got a place to put my instruments here. But we want to get everything cleared up, at least initially. So I'm going to be like this. I'm going to continue to maintain a little pressure. Even when I put my dominant hand on, I'm always using my bottom finger or so to put some pressure on here. So the tip of the tubular retractor is always on a little bit of bone. Then at that point, I am going to grab it like this. Now I've got it like this, and I'm going to just get myself positioned a little bit here. It's going to be docked on the bone. I'm going to start to actually now grasp it so that I can not only put some pressure on with my thumb and maybe my little finger, but I'm actually starting to use the upper fingers as a trombone. And that way I can go up and down to the operative site, and it leaves my right hand, my dominant hand, free to start to use any instrument. So if I'm going to grasp some soft tissue, I'm just going to go like this. In the meantime, the whole tube and the scope is always completely controlled by my non-dominant left hand. So there you go. The idea is 2 things. One, put some pressure on the top of the fluid intake valve so that you can always keep it docked. This way it prevents the scope from wandering or the tube from wandering around inside. And the second thing is maybe put 1 finger or 2 fingers up here so that you can always trombone the scope, and so you are going in and out of the operative field the same place. So this is to hold it fixed, and this is to get your point of view. Your dominant hand is used for instrument control. And that's going to be the same, I don't care what procedure, cervical, lumbar, and no matter what procedure you do, it's always going to be the same type of thing. even transforaminal, it'll be the same type of thing. So that's how to hold your hands. It takes a little practice, but in the end, it'll just come second nature after a while. Okay, let's jump to an actual surgery where I'm going to show you a little bit of this technique in action. This is the tubular retractor, the tube, and the way it's actually docked a little bit on the bone now, but the way that I like to hold this is to always have a little pressure, sometimes with my thumb, but it's always got to have a little pressure to dock it on the bone. And this is I'm right-handed, so this is my left hand. I just kind of hold it like this, so I'm always got maybe some thumb pressure or something. Then the next thing that's going to go in is the scope. This is a spinal stenosis case, so things are a little bigger, but you can see that I've kind of got I've got my fingers here, my 3 fingers here, kind of holding the two, and now I'm kind of, so I can actually push down, but I'm using my thumb as kind of a control so that things don't advance too fast in here, and you can see I'm kind of using it like a trombone, and the TV screen is becoming a little bit more clear in a moment. But now you can see I've kind of moved my hands up, so I'm actually, my little finger and my ring finger are kind of touching the top of the tube, but I'm always able to exert a little bit of pressure. And you can see now my thumb has moved up to the little place where the valve comes off of the endoscope, so I can kind of trombone it, but I've got good control. So my little finger is used to put some pressure to push down and dock it on the bone or wherever I want to be. And then my upper fingers, my thumb in particular, is using to push the scope in out. So you can watch the TV. Now with my thumb, you see I can kind of trombone the scope up and down so you can see. And then with my other hand, now I can pass an instrument through the middle, but I've got great control because I'm pushing down with my little finger, pushing on the top of the tube so it docks on the bone. You can see I'm fixed on the bone here, and then I'm able to move the scope up and down like a trombone, and then I'm able to cut with the Kerrisons and be performing the surgery. No matter what kind of case you're doing, this is going to be how you should be holding the scope. So in other words, once I get positioned, my bottom finger or so is pushing down to dock the tubular retractor on the bone so it doesn't move around. And my upper, then I got a little space here, and my thumb is moving like a trombone. So I can move around, but I'm always docked. So anyway, the idea is I can go up and down. I have good control of the scope because it's docked. And remember, I'm just always pushing down a little bit with my left hand so that the scope always stays where it's supposed to stay. All right, trigger flex. So again, always putting a little pressure on the tube so it stays put wherever you want it. Just dock it on the bone somewhere and push down. And then instruments are with your dominant hand. Now, in this particular case, where I'm just doing a interlaminar decompression, and so I'm about ready to, I'm just creating the space for the tube down here. But no matter what you're doing, okay, Kerrison, no matter what you're doing, the idea is always the same. Be able to move the scope in and out like that. The thing is always going to be the same. No matter what kind of work you're doing, the tube has to be docked, and you have to do that by putting some pressure on these lower fingers here. And as you have, once that's the case, then you can use your thumb between the valve and the scope, depending on what size your hands are, so that you can, again, move it up and down. So you're fixed, but you're able to, with your hand, to kind of go up and down as well. Harrison? And that's the whole concept, is to stay put with, so that you don't have to always keep finding where you're located. Thanks for watching. I think that holding the instruments is probably one of the most confusing things for people beginning these endoscopic techniques. And I just want to remind you that it just starts with the obturator. No matter what you're doing, it's going to be docked on some bone. The tubular retractor goes in next with the bevel away from you. When it's fixed in place, again, now the tip of the tubular retractor is docked on something, and the point, you've always got to hold a little bit of pressure down so it doesn't wander around. Next is going to be the scope, and at that point you can actually now switch a little bit so that you're going to hold some pressure on the scope with your lower, maybe your little and ring finger, and then your thumb and index finger can be used to trombone the scope. So it's docking it and then using the other top fingers to go up and down completely with your non-dominant hand. Holding your instruments is the most basic and essential skill set needed for endoscopic spine surgery. This is how I've been doing it over the past couple of decades. It seems to work fairly well. The most important thing is to dock it, and then next is to trombone the instruments. Learn this, and your career in endoscopic spine surgery will just progress rapidly. Go out and practice. Thanks for watching.